So I think, first of all, I want to say thank you for the privilege of being here. I want to thank PK and Dirk. I also want to point out that I think Peter's last case example of a patient who stayed patent with the Viabon for 11 years now is really a nice example of how these technologies can help us quite a bit depending on how we apply them and who we apply them to. I do think we need to recognize some of the benefits of all of these different therapies we're talking about, plus the limitations. So the focus of my talk, these are my disclosures, the focus of my talk is DCB therapy or drug-eluting therapies for in-stent restenosis. And I think that we all need to just simply recognize that drug elution is a part of this algorithm, regardless of other adjuncts. So stents have been shown to be superior, of course, to PTA alone. Stenting has been a dominant treatment approach for many years, but we're now moving away from full metal jackets, and atherectomy and DCB are helping us do that. Clearly, we've seen that as lesion length increases and as calcification increases, we're challenged with our DCBs, and there's no doubt that scaffolding will remain important going forward in the future. So we do need to consider that we'll be fighting this in-stent restenosis for quite some time. And the stents themselves may be part of the problem here and part of the trigger. So we recognize now that oversizing stents probably acts to cause inflammation in the vessel. Stent fractures obviously are associated with in-stent restenosis and loss of patency. So these are some of the problems, and I think our stents are probably helping to contribute to the problem of restenosis. So these are some of the options we've been discussing already for ISR, and I'm going to be focusing on anti-restenosis therapy with drug-coated balloons primarily. So obviously, we've discussed this issue that there's some late catch-up for these balloons, and I think this is probably true. But I think we should also recognize that not all of these balloons are the same. There are different properties in terms of their excipients and their dose. And at least in the example of the impact SFA, all the way up to 3 years, we're really seeing very little catch-up in terms of primary patency. So that's encouraging. We'll have to see how these other balloons do over the longer term. When we look at support for DCBs in in-stent restenosis, there are a couple of major types of data that we have. Number one, we have a few randomized controlled trials comparing DCB to PTA, and then we have some prospective registries as well. I'm just going to go over a few of these, some of which we've already had discussed today, so I'll be somewhat brief. But among the randomized trials, we have DEBATE ISR trial, the FAIR trial, and the PACUBA trial. These have, again, already been discussed, and I just want to bring your attention to the quality of these studies, so to speak. And so each of these studies is comprised of patient sets that are not enormous. They're in the 100 sort of 120 range in terms of patient populations or patient size. They've all shown a very similar trend. DCBs clearly outperform PTA across the board in any of these randomized trials. And generally, with the exception of the PACUBA trial with the freeway balloon, generally very good results. So an 80% or 70–80% primary patency rate at 1 year is quite an advantage over PTA, which has been the historic treatment for these patients over and over. And freedom from TLR follows that very reasonable patency with the DCBs and doing quite well compared to PTA. When we look at prospective multi-center registries for DCB in ISR, two come to mind. I think the most important and most sort of impactful is the IMPACT Global Registry ISR imaging cohort, and then this other PLACER trial, which I'll discuss briefly as well. So this is the outline of the IMPACT Global Registry. It was a very large registry of 1,500 real-world patients. Most of these patients were followed as TLR for the primary endpoint. The exception to that are the 3 imaging cohorts that had core lab adjudication for the follow-up imaging to determine patency, and that's the real strong point, I think, of this registry. Included in that was a de novo ISR cohort of 131 subjects. And I point this out just to say that in terms of all of the other core lab adjudication and sort of the rigor of the trial, this was very similar to the randomized trial. And so I think that's why this is a helpful registry to use to evaluate how these devices perform. In this trial, or in this subset, this imaging cohort for ISR, there were 131 patients. Mean lesion length was quite long at 17.2 centimeters. Majority of them were calcified, and about 1/3 of the patients had CTOs. Had a very low thrombosis rate of 0.8%, so there were no safety concerns here. And if you look at the 12-month primary patency, it was almost 89%. And so this is something that was really virtually unheard of prior to the use of drug elution in treating ISR, and I think that stands as a pretty good result. Moving on this other registry. This registry is a multi-center French study, again showing very similar findings. This study also used the impact admiral DCB, not a particularly long lesion length of 8.6 centimeters. If you look at the primary patency rate, again 12-month primary patency rate akin to what we saw in the impact global registry, and at 18 months there was some drop-off, but still quite high at nearly 80%. So if you take some of these studies, these registries as well as randomized trials, we find, and we compare them to other modalities, we find that they actually do pretty well. So we've talked about Excite ISR trial. Certainly some of these studies we're discussing with DCB use in ISR outperform the Excite trial or the laser arm of the Excite trial. Even with the Reline study with the Viabon, again, we had pretty good results with the Reline trial, and you can see the primary patency is around 70% at 12 months, or sorry, 80% at 12 months, which is again very similar to what we saw with some of these other studies. Just moving on from there real briefly, I want to sum up two other issues. I think that we've all discussed the fact that combination therapy is probably where we're going to have the most bang for our buck in using these devices. There's a good rationale to debulking followed by using drug, but just debulking alone, I think we all agree, is obviously not adequate. This study has already been discussed, and I'll just point out that I think the results of this were pretty good in terms of primary patency rates in the 78 or 79% range at 12 months. But again, this is not that much different than we see with DCBs in most of these series. And the difference is here we're leaving more metal behind. And so I'm not a particular fan of relining with more metal when we can get away with drug elution without the use of another implant. So in conclusion, I'd say that despite a movement away from liberal stent use in the SFA, there continues to be a need for scaffolding in some complex lesions. In-stent restenosis will continue to be a common problem, even with some of our most recent, most current stent technology. PTA or debulking alone is really insufficient for achieving optimal long-term results in ISR, and I think that drug-coated balloon technology, either alone in combination with one of these other therapies, is going to become the new standard of care. Thank you.